At exactly 2 o'clock South African time, good afternoon to you, the Conversations with Eminent Women family. Thank you so much for your time once again as we go live on this very important conversation that we'll be having today. March is known as Endometriosis Month, and so we'll speak about this with some of the ladies that have joined me this afternoon. We'll start off, joining me is Dr. Koketso Pule, who is a gynecologist and obstetrician as well. We also have Olebogeng Kgosilentswe, who is an activist, an endometriosis activist, and Bontle Moka, also an endometriosis activist. And we speak about endometriosis. You know, in the poster, if you had a look at this poster that we created, it says the good, the bad, and the ugly. And I really wonder if there is good to it. I suppose there may be some, but we'll find out from the ladies what they have to say about endometriosis. And as we welcome them, ladies, thank you so much for your time. Good afternoon.
Good afternoon. Thanks for having us.
Thank you, Tshegohaco. Good afternoon to you too.
So let me start, Dr. Pule, let me start with you because I think I want to speak really about the good and what endometriosis really is. But let's start at that very point. What is endometriosis in the bigger scheme of things, and just help us understand it in a better way?
So endometriosis is a chronic condition where the lining that is known to be in the lining of the uterus, inside the uterus, grows elsewhere outside of the uterus. So it can grow in your pelvis, in your tubes, and in rare cases, in your chest. And every month when you go to your cycle, you get menstrual cycle or hormonal changes in these areas as well.
It sounds painful.
Absolutely, it is painful, but the distinguishing thing about endometriosis is that you can differentiate it from normal period pains because it's severe and it can become debilitating. So once a woman is not able to function and perform her daily activities or work, or not being able to just get out of bed or live her normal life, when that pain becomes that debilitating, then you have to have a suspicion that that particular woman might be having endometriosis.
Sure. And we'll come back, Dr. Pule, to the issues, of course, of, diagnosis, treatment, and all of that with you in a short while. Olebogeng, let me bring you into this. You're an endometriosis activist. Perhaps share with us in detail your journey and how you were diagnosed and really what you went through. You hear Dr. Pule speaking about the pain as well that you may feel. Just share with us your journey in detail, your diagnosis, like I said, but also how you are doing now.
So I didn't get diagnosed until 2024, the middle of 2024. But I can just tell you that I grew up with this sharp pain on my lower left abdomen, and I couldn't identify what it was. I had been from several kind of doctors. It would get so bad that sometimes I couldn't walk properly, or I would limp, or I'd always have to hunch over and hold the area that's aching. I also grew up with a 7-day period, which was very heavy and very painful. But those are things that I had come to normalize because a lot of young girls and a lot of women around me also go through the same thing each time they enter their menstrual cycle. But then one day, as we do regularly as women, I went for a regular gynae checkup. And when I explained, and this was a new gynae, and when I explained my symptoms to her, she said to me, the 7-day period is not normal. Have you always had that? I said, yes, for as long as I was on my period at the age of 14, perhaps, I've had this kind of long period. And she said, that's not normal. She said, how painful is it? I told her it was excruciating. I told her about the sharp pain on my lower left abdomen. And she said, I think we may need to check this beyond just the regular checkup because it looks to me like it's symptoms of endometriosis. And I just simply couldn't believe it. And she said, but you have to agree to come to do, she called it a day process at the facility where we're going to check, but we'll use a laparoscopic camera to go through and see if you really did have endometriosis. Fine, I booked the procedure at the hospital. It ended up being surgery. That through which was stage 2 to 3 endometriosis was discovered in my body, alongside another abnormal cyst that was growing and bleeding as well. So that was removed. So it was quite a painful surgery. It was a painful discovery. And then I went through the conversation of getting onto the treatment, the kind of food that I'm supposed to now take. It took quite a while, I think over a month or 6 to 8 weeks maybe, to recover from the surgery or the procedure. I had 4 incisions on my lower abdomen. And so that was quite painful and quite shocking to know that I had it. I had read about it. Some of the friends that I have had experienced it, but I didn't think, that a regular checkup at the gynae could result in that big a thing. So as far as how I am and how I'm doing, I am on chronic medication now. The pill is called Visan, and I think quite a few people, women that take it, that have endo as well, take that. And it's a pill, an oral pill that you take every day, maybe at a certain time of the day. That makes me to not have the pains, to not have the bleeding, but it also makes me to not have my menstrual cycle every month. Which, is a bit worrisome to me, because, and maybe the doctor can help us clarify what the impacts of that are in the long run, if any. So that's how my life has changed. I've had to change the way I sleep as well, my sleeping patterns, because I've come to learn that a patient of endometriosis becomes very tired, becomes very exhausted, and they need those hours of sleep. I've had to change my diet in certain instances. So a lot has had to change. I'm kind of living around the illness now. Each time I'm taking up something, I need to consider that I now live with this thing. The cold weather also affects me sometimes. So it's quite a journey. I'm still learning how to live with it. And yeah, looking forward to hearing from other women how we can better grow, still living with this illness.
And we'll come to, some of the pointers that you made, changing your diet, sleeping differently, and all of that, just for you to give us more detail as to how you're sleeping now, but also what are you not supposed to be eating? Because I can imagine also, Dr. Pule, that it might be different for each woman. Before we continue then, Bontle, let me bring you into this. Your journey with endometriosis, how did you find out? When did you find out?
Yeah, thank you. I think for me, there's so many similarities and yet there's so many differences at the same time. For me, it was also, painful periods from day one, 12 years old. And then for years, I just thought, that's just normal. That's everyone else goes through this. And then at about like 16 years old, I was just in this excruciating pain. It literally woke me up out of a nap I was taking and I was just bleeding. But I was rushed to the hospital and I was told we can't see anything, and I literally felt like I was going to die, but no answers. And kind of few years went by, still the same thing, it was also the 7 days. At some point it was even 22 days, 19 days here, just constantly bleeding. It was just pain, and then at some point I was told fibroids, but I was told that they're normal, they'll go away. So I was like, oh, okay, let's keep moving then. And then I'd say about 9 years later, from turning 16 years old, that's when the doctor said that, she's able to identify this. This was not yet through the laparoscopy yet. My mom had it. She had about 18 procedures because of endometriosis. And so I kind of knew what I thought and suspected that I may be dealing with this, but I never really got confirmation. And at the point when the doctor said, "Hey, I think this is what it is," I was immediately put on the Visan. And again, for me, my experience with Visan is very different, So I've heard many people say it has worked for them, but for me, unfortunately, I ended up in hospital because it just seemed to aggravate everything for me. And at that point, I felt that I want to take the natural route. homeopathy. And again, I think I was also very traumatized from knowing my mom went through so many procedures and back, and that journey, I told myself I didn't want the invasive route or anything like that. But unfortunately, about a year later, I was doing well with the, diet, holistic treatment, all of those things, and was much better than at the point I got that diagnosis. But I got fibroids, and then in 2024, I ended up being diagnosed with PCOS, and then a couple of months ago, ovarian cyst rupture, and then my fibroids came back. So it's just been a long journey for me of just dealing with all these different things. And yeah, so my journey is, for me, it's a bit confusing for me, but it's been a journey of pain, of trial and error, and just really trying to figure it out with all these different things in my body coming into one and dealing with that. And so it's been difficult.
Dr. Pule, Bontle, we'll come back to the homeopathic routes that you tried to take as well. But Dr. Pule, you listened to the two ladies. They've taken the same kind of treatment, but it has not handled them both the same way. And I suppose this also speaks to what I said earlier, that we definitely are different as women, and things will not necessarily work. If it works with the one, it may not work with another lady. But there's also the issue of diet that both ladies have now spoken about, Olebogeng and Bontle, that they spoke about the diet. Is there something that we can take, that we can eat, that we shouldn't be eating to avoid getting endometriosis?
So lifestyle changes or your diet is not really preventative. So endometriosis is as I said, it's a chronic condition and it results in inflammation. So any diet like natural diet or what we refer to as anti-inflammatory diet can assist in alleviating some symptoms, but it's not preventative. So from both their narratives regarding their stories, one has had what we call heavy menstrual bleeding, like bleeding excessively when they're on the cycle. That's one of the associated risk factors. A short cycle that could be less than 27 days could predispose you to that. So these are associations. So with Bontle, with her mother having had endometriosis, there's also a genetic component. So there are many theories as to how endometriosis starts, but the common one is the genetic theory that most will understand. Other causes or other theories are just theories, nothing really proven. But short cycles, people who are underweight, people with heavy menstrual bleeding or menstrual irregularities are at risk of developing endometriosis. An anti-inflammatory diet can help with alleviating the symptoms, but it's not really preventative per se.
Why is it so difficult to diagnose? I mean, both Olebogeng and Bontle speaking about being, sent, having the pain, and you just never get diagnosed in your first visit to a gynae or to a GP.
Yeah, I think the issue is always awareness and the overlap in symptoms with most gynecological ailments. So Bontle has had other issues. It was not just the endometriosis. It overlaps with symptoms of fibroids. It overlaps with symptoms of PCOS. It can overlap with symptoms of stomach issues. So if you're not well-versed in terms of dealing with endometriosis, you can pass it off as something else. But you try one treatment, it doesn't work. Any woman who is coming to you childbearing age and they're having debilitating pain when they are going to their cycle, endometriosis should be one of your differential diagnoses. It shouldn't be at the bottom. It should be in the same differential diagnosis as your fibroids, PCOS, and other pelvic issues. So working yourself through the diagnosis and doing the appropriate investigations to exclude one or the other can help you get to a diagnosis. And some people just end up in the primary healthcare sector where not every primary healthcare professional is akin to what endometriosis is or how to treat it. So when you are at a healthcare professional, be it a GP or a nurse, and if they have reached their limit or they're not certain of a diagnosis, there are always pathways to refer a patient, especially when the treatment you're giving is not working. Rather refer to a specialist or someone who is specializing in women's healthcare or gynecology.
Olebogeng, let me then bring you back here. You hear the doctor speak about the difficulty of diagnosing this particular disease, endometriosis. For you, like you say, it was difficult as well for someone to pin it down to say this is what you possibly could have. It took a while, I suppose, right? And in between that time, what were you thinking?
It really did take a while, Tshegohaco. I mean, you can imagine from the ages of 14 years and only getting a diagnosis well into my mid-30s. We're talking about 15 years or more here. In that time, because of the lack of awareness and the lack of information, I just thought this was a regular thing that's supposed to happen to a woman. Again, because even other women around me have, even worse kind of symptoms when they go on their menstrual cycle. Bontle speaks of her mother. I remember that my mom also had this sharp pain on her lower left abdomen. She has also had it checked out. I had, when it got bad, when I was in my late 20s, the sharp pain on my lower left abdomen, I went to get a CT scan. And I paid quite a lot of money for it because we believed that maybe that could tell what this thing was. But we walked out of the hospital and they found nothing. So we end up spending such a lot of money, making mistakes, thinking this could be one thing or the other. We end up normalizing the pain. We also end up carrying or living with the myths that we grew up hearing, either from our communities, our grandmothers, our friends, and we internalize those and you just kind of run with it and think that this is how the body of a woman operates.
Bontle, your story, very heartbreaking because you had so many instances as well and other things, like Dr. Pule said, in between trying to get to the crux of what it is actually that you're dealing with. For you to then finally get this diagnosis, what are some of the remedies that you tried to take? Like you say, there was a bit of homeopathic solutions that you tried to work on. Are you still doing that? What were those?
Yeah, I think it's really been trial and error. So again, I think like the doctor was saying, it's not like preventative and it's not a solution. It just can help. And I think after so many years of, dealing with pain, you get to like learn your body and certain foods that might make it worse. It's not gonna take it away 100%, but I know, for example, when I'm kind of in that state or like I'm getting that bloating or flare up, I need to stay away from bread. I completely cut out dairy, cheese. I guess gluten is an issue, but again, there's some days that I have it and I'm good, I'm okay. The biggest thing for me is pain management, but you try one painkiller for a certain time, then it doesn't work, so you stop it for a while and then you go and try another one for a certain period of time, then you go back to another one. So it's different painkillers, Zephyr Rapid for me has been the most helpful. Sign leave, and then because I love my herbs, but again, it's not a cure. It helps sometimes. So if I'm trying to help that bloating, I get some fennel seed tea, and that sometimes works for me, but sometimes it doesn't. So even the things that I've done in that year I got diagnosed, I had to be consistent. I had to be so aggressive with it because I was just, I think, so scared. And because I was so aggressive with it, I did see improvements in everything. By the time I got the diagnosis, I was hunched over. I lost weight. I couldn't walk. I was pale in with my complexion. I was so pale, I was just deteriorating almost. And that kind of just helped bring me back. But even though now I kind of do those things, but I'm not fully consistent. But I've seen the power of doing those things, but it's not a solution because even up to this point, it didn't stop me from getting these other things again. Didn't stop the PCOS, it didn't stop the fibroids from coming back. And I also don't believe in like punishing myself all the time because I have very little control on what's going on, so these are things that just have been helpful, but you can still do everything right, exercise, eat right, anti-inflammatory, but it doesn't always help.
You mentioned that when you got the diagnosis, Bontle, that you were scared. What scared you the most about getting such a diagnosis?
Um, I think really losing a part of who I imagined I would be. So I had to like rethink my life, my identity almost, and I had to picture myself almost differently. Like I remember at the time I'm still young, but I remember thinking that, okay, if I get married, I may have to become this kind of wife. If I get into the workforce, I may have to become this kind of corporate girly, I have to like readjust how I show up in the world now. And then also becoming a mom, because for me, I have both tubes blocked now. And, there was so many things I was afraid of, but there were things that were confirmed down the line that like, had I not thought about those things and yeah, it's fear. You're worried about all these things that could happen. I don't know if I would be in this position where I'm okay enough to speak about it, but I was very much scared. I was scared it would get worse. I was scared that I would have to go through multiple surgeries like my mom and lose my womb, all of those things and essentially lose who I am, you know.
Mm. Olebogeng, what happened with you when you first found out? How did you feel on that day?
I'll be honest, I wasn't as scared as Bontle, and I think the reason for me not feeling that way was because I had been contributing to a lot of women's health conversations. And I was particularly intrigued by this endometriosis because I started seeing these women post on social media, these yellow ribbons, these yellow hearts, and yellow endometriosis. And I just had the curiosity. And I think it's because of, where I worked or my career. In its nature was to be inquisitive and just wonder what is this. So I used to do quite a lot of research myself on endometriosis. And I used to have a platform where I was a radio contributor. So I would speak about that, trying to, in my own way, create some form of awareness. So when I then eventually got diagnosed, it kind of just said to me that, okay, this is bad, but I can now speak from a position of knowing. If I have to have conversations on the radio or on social media, or on any other platform, I will be speaking from experience. It's one thing to tell people about something that you don't even know yourself, and it's a totally different thing to tell people about something that you know that you experience. So I decided right on the spot to take it as a learning kind of journey for me, and as an empowerment kind of journey where I would now, obviously because I have it, I'd now have to research more. I'd now have to have more conversations. I'd now have to learn more. And I just kind of said, I'm going to quickly turn this around. And I'm going to make it a learning thing for me and other women around me and elsewhere. So for me, I was fortunate in that, one, it wasn't as severe as Bontle's condition, but two, because of the information that I had, it was somewhat of a preparation going into now finding out that I had endometriosis.
Dr. Pule, both ladies speak about, Olebogeng maybe not as scared, but there must have been some kind of concern, of course, like Bontle said, with what happens next, what do you do next? When such diagnosis is given to women, is there therapy that is offered?
Yes, so it's a whole psychosocial thing, and getting a diagnosis of a chronic condition, knowing that you're going to have to live with it for the rest of your life. It's very imperative to have a multidisciplinary approach, including your psychologist, your other allied members, your physiotherapist. So it's a lifelong condition, and it's important that we sit down with the patient, counsel as much as we can, because it does tend to also affect people's psychosocial well-being. Your mental health can get affected. Living with chronic pain that is debilitating can also take a knock on your immune system as well. So there is therapy, there is counseling, there are psychologists that can sit one down, but I think it's also being aware, knowing what the condition is, and the healthcare professional making the diagnosis, not to brush off the consequences that come with the diagnosis. And it's very important to offer patients psychological help and to protect their mental health that comes with, yes, we make the diagnosis, but you know that you're going to have a very long relationship with your patient. So it's important to support them in every aspect. So regardless of what diagnosis you get, if it's taking a toll on your mental health, we are supposed to offer that support. So it's a multidisciplinary team that has to be involved. So yes, I absolutely advocate for therapy and counseling.
Dr. Pule, let's speak about lifestyle changes. Both ladies have spoken about this. What needs to change once you get that diagnosis that can be scary, of course, once you get told that you've got endometriosis? What are some of the lifestyle changes that one would need to take into consideration?
So just as a rule with everyone, whatever condition you have, always taking care of your body from the beginning before you get any diagnosis is very important. Keeping active, living a healthy lifestyle, alcohol, drinking, smoking, it's across the board. It affects everything, every condition, even endometriosis. So working it backwards, we've touched on the diet, anti-inflammatory diet, meaning that eat healthy. If you're drinking, reduce your alcohol intake or stop completely, stop smoking, exercise, maintain a healthy BMI. So being underweight is also a risk of getting endometriosis. Also, being overweight is also an issue. Caffeine exacerbates symptoms as well. Caffeine will exacerbate symptoms for anyone who is within their cycle. It contributes to the whole bloating, the cramps, and all of that. So a healthy lifestyle can help alleviate those symptoms. So also exercising, keeping active, having a healthy sleeping routine. So not having enough sleep or not sleeping as you should, or the recommended hours, can contribute to stress levels, increased cortisol levels, that can contribute towards the inflammation of your body. And being self-aware, tracking your cycle and the symptoms that are associated with your cycle is also very important. So also endometriosis can affect your social relationships. So once you start realizing, okay, I'm not enjoying intercourse so much because it comes with pain, because that's one of the symptoms of endometriosis. Be aware of your body and the symptoms that you're going through, especially around your cycle. Track them down. If anything is amiss, leave Martha next door, who might have normalized pain or have pain for other reasons. Take charge of your own health. Seek a healthcare professional that can answer your questions. If you are in doubt and you're not getting questions, you are more than welcome to seek second opinions. But don't take other people's stories as the gospel, and it's not a one blanket approach. People will have different symptoms at different stages, and what works for one person is not necessarily going to work for the other person. So just being self-aware of your body, keeping active, sleeping well, a healthy diet, and avoiding your alcohol, your smoking, the caffeine, high fatty diet. all of that may help in alleviating the symptoms.
Mm. Olebogeng, you mentioned this when we started off the conversation that you had to change a few things. Share with us what you are not doing anymore.
And it's the normal things that we grew up with, like the carbohydrates, the pap for me, the bread, like Bontle mentioned, gluten, the dumplings, all of those wholesome, homey food that you like. And I must also add, I had to stop. I must also add that a gluten-free diet is very expensive. So it can be challenging to maintain that. You will have, I mean, a loaf of bread that's gluten-free is 60 Rand.
Sure.
Exactly. Pasta that's gluten-free is more than 60 Rand. So it not only does it affect your diet, it affects your pocket as well, because you are now replacing and substituting things that you used to eat that you know that you no longer can eat or that you should avoid. So it's things like that for me. Red meat. I'm a lover of meat. I grew up in a household that loves meat. My dad slaughters animals for fun. That had to change in my life, unfortunately. I mean, I still do eat, but I can't indulge and enjoy fully like I used to. Sweet things, dairy products, like Bontle mentioned. So it's like an overhaul of what your normal day-to-day things. And you find that when you go to the stores trying to, okay, let me stick to this diet that now helps me not be inflamed, it's quite expensive. I've had to go to a dietitian to say, okay, what can I eat? What can't I eat? But it's not a luxury that many can afford. Do you know what I'm saying? So it's the challenges of having and living with endometriosis are many. They are endless and they vary from person to person. I also wanted to add that when the doctor spoke about mental illness and how it affects one person, I remember now that I actually experienced that little bit of fear when it came to issues of fertility. I have always decided for reasons that I know that I was not going to have children. It was a decision that I wanted to stick to. But when I got that diagnosis, I suddenly felt like, do you really not want to have children? Because it's one thing to say, yay, I choose to be childless. But now and it's nice when it's your choice. But when you have now a disease that can actually force you to not have children, you start thinking differently about your future. Like Bontle said, you start thinking differently about your own identity. I've always identified as childless, but I am starting to think, okay, maybe it won't be so bad, because it was always nice to have the option to not be childless or to have a child. But now it's almost like, do you really have a choice? You may not have a choice in the end. And so that was what was, one of the scariest things for me.
Bontle, we'll come back to what you've had to change, because I want to quickly bring in Dr. Pule here. Dr. Pule, Olebogeng speaks about the childlessness. And is it really the case, right? How many women do we actually see that do not have children because of endometriosis?
Yeah, so about 50% of women with endometriosis may struggle to conceive, right? But it doesn't mean that if you have endometriosis, automatically you will not have children. So it has different stages, and for multiple reasons, people can struggle to conceive. So what it causes, as I said, it's inflammation. And what inflammation does in your body, it causes scarring tissue. And with the scarring tissue as well, it can affect and block your tubes, or you can grow cysts of endometriosis that we refer to as endometriomas, and that can affect your ovaries and your eggs, your ovarian reserve. So, and those effects come in different stages. We have like stage 1 to 4, and depending what stage you're in, all of those effects can come into play. So of all people we treat for infertility, about 25 to 50% of them when we investigate them, they have some endometriosis. So it's not an automatic, you have endometriosis, you'll struggle to conceive. And there are also different treatment modalities depending on what the patient's goal are. Is your primary goal to address the pain, or is your primary goal to try and conceive? So it's not a sentence when you get the diagnosis to say that you will struggle to conceive or you won't have children. It depends how far the endometriosis is and to what extent has it affected your pelvis.
Is it possible to treat both, to be able to say, I want to stop the pain and I want to have children?
Yes, so when you sit down with a patient, some patients come in because they just have severe period pains. As I said, most people we investigate for infertility when they come in, some of them have endometriosis. So you have to listen to what the patient is more worried about. Are you more concerned about the pain, or are you consulting because you are struggling to conceive? So it has to be a collaborative approach. So you can treat both because there are treatment pathways that we take depending on what the concern of the patient is. If someone is coming in just because they're having severe period pains around their cycle, we start with pain medication, hormonal treatment. If someone is coming in because they're struggling to conceive and they're having pains, we can address the pain, investigate why they are not able to conceive, because there are other reasons why people also struggle to conceive other than endometriosis. So you can address both at the same time, but the primary concern of the patient always has to come to the forefront and be prioritized.
Bontle, what did you have to give up, so to speak, that you really would love to still enjoy after your diagnosis?
What did I give up? So I'm at a point now where I think I just manage, and I'm so aware of myself that because I love something like pasta and I love my cake, I know that I'll have it once in a while. So it was maybe a few years ago that I said I did a hard no dairy, no bread, no, the caffeine, all of those things. I did a hard, this is the journey I'm going on and I'm trying to manage it. And obviously now I'm getting back into it because of all the things that have come up. But I think the struggle mentally and emotionally has taught me to be a little bit more kind and gracious to myself, so that I don't feel like what I'm dealing with is already hard, and what we're going through it's so difficult. I used to psychologically tell myself that I'm punishing myself if I eat so strict, and if I can't have this, I can't have this. So now I just say I'm allowed to have this. I just don't as often as, I should or would want to. So I indulge every now and then. That's, I think, life. And I think the reality is sometimes it's not sustainable. It's very expensive. And I mean, I'm currently in the US, it's expensive, the back and forth, it can get up there. And I think for the average person, it's sometimes choosing between painkillers and bread, honestly. So I allow myself, I'm kind to myself, and I am also I limit myself here and there, but I don't think I've done a hard cut on anything. I can't think of anything right now.
Did you get any therapy?
I went to the Lord. I had a bad experience with a therapist, so I fully believe in it. But because I also at the time was dealing with, sexual trauma, which is what, I think some doctors have a theory that there's a connection with that. After, being assaulted, it affected me physically, and I think I think the doctor mentioned, what is it, psychosomatic, like it's like everything was happening at the same time. So then to see a therapist for me and then not have a good experience, although I fully believe in it. My mom's a counselor. I mean, I just I wasn't ready. And so that's how I ended up with the advocacy. And then I wrote my book. So for me, it's been a spiritual journey in terms of my healing. But I fully advocate for getting therapy. I just didn't have a good experience.
Sorry to hear that. I'm really sorry to hear that. Ole, did you go for therapy?
I didn't particularly go for therapy for endometriosis. I was already going through counseling just because I was going through like a change in my career. I had done a certain career for like 15, 16 years, and then I went a totally different direction. And that kind of made me lose a sense of who I am because I had attached who I am to my work. So I was mourning that a lot. And so I went to counseling for that. And as I was going through the therapy for the work career thing, I got then the diagnosis, and then I started living with endo. So fortunately for me, it worked concurrently, so we would have those conversations in therapy about the women's health issues that I now live with, as well as what I had initially gone to therapy for. However, I do think that even with our doctors that diagnose us, a lot more information is needed to patients. I feel like my experience could have been better, but I felt like a lot of things, it felt like the doctor sort of thought I already knew certain things. So I constantly had to discover things along the way and call to say, oh, does this mean I can't eat red meat? Oh, no, you can't eat red meat. I'm just like, if I didn't ask, yes, I wasn't gonna know. So I feel like we need a lot more information to be forthcoming, so that we are prepared. It's not just, okay, we've removed the endo that was going in your body, go home and heal. Patients need to be equipped with what we are doing as we are healing and beyond that. Another thing that shocked me was the price of the medication that I take. It's expensive. And I've come to learn that medical aids don't recognize it as a chronic illness. Oh, no. They don't recognize that kind of medication that I take as chronic medication, which means I can't get a discount on the medication. And even if I run out of funds in my medical aid, I have to self-fund, to take the money from somewhere because I need to take that medication. So it's a lot of information that I found myself having to find out for myself or discover or stumble across that wasn't offered at the time when I was going through my surgery. And I feel like that could have been really beneficial had it happened at that time.
Sure. Dr. Pule, you hear what, Olebogeng says now specifically about, just being forthcoming from the doctors. She spoke earlier as well about, stage 2 or 3 endometriosis. Let's just speak as well about the different stages of endometriosis. And where do you think your colleagues are lacking when it comes to sharing the information about this is the illness that you have, this is what you need to not be eating or just maybe cut out, and how that can be improved, that communication can be improved?
Okay, so going right back, I think most women get dismissed because when you present with women issues at 14 years old, you tend to get dismissed. Nobody thinks that an 11-year-old will present with pelvic issues or gynecological problems. And people think that older women, people wanting to have children in your mid-20s, late 30s, are the people who are supposed to see a gynecologist. But from a very young age, once you start your period, even prior to that, you should be primed to seeing a healthcare professional as a young girl who needs to be empowered in terms of their own body. So I urge parents to be proactive about that and not dismiss young girls with their symptoms, thinking that it's womanhood issues. You shouldn't be going through it. We need to be more aware and more receptive to the young girl. And in terms of my colleagues, I think what's important and what I've learned in my professional is knowing and understanding my own limitations. I think healthcare professionals hold on to patients because, yes, you're a healthcare professional, some are running businesses, they hold on to patients without referring them or understanding or knowing their own limitations. Once you are in too deep and you're out of your depth, there's no shame in referring to the next person saying, I'm beyond my limits here, please assist with 1, 2, and 3. Someone who's more knowledgeable on the condition. If you've done what you can and you've reached your limit, there is no point in keeping a patient you're not able to assist. And then in terms of counseling, as I said, it's a chronic condition. It's a psychological condition. It's a physical condition. It does require a multidisciplinary team. So when we do give patients a diagnosis, regardless of what the diagnosis is, it's a new thing in someone's life, and it comes as a shock. You do have to take time to counsel the patient, go through the basics, because I suppose in that first consultation, when you're giving someone a new diagnosis, there's only so much you can take in at a time. But because it's a chronic condition, you have to sometimes tailor and scale the information that you give the patient, depending on what mental state they are in. And sometimes you have to repeat things. You have to repeat things because this is a lifetime condition. So I do urge my colleagues to sit down. You are as a primary caregiver or healthcare caregiver, we do need to invest time in counseling patients thoroughly in terms of their diagnosis. And counseling also empowers the patient to know when to seek help, what are the red flags, what I should do what I can do to make my life easier, so that it's not always a back and forth. It's a collaboration between the patient and the healthcare professional treating the patient to, at least at the first diagnosis, give the basic and do the counseling. But the counseling is also ongoing, because you may counsel someone and give a broad indication of what the condition is, but you won't necessarily experience the same thing. So that's what I'm saying. Counseling is ongoing, and it needs to evolve, because not every woman is the same and will experience the illness in the same way.
So if a young girl, or if young girls faint, Dr. Pule, during their menstrual cycle, could that also be associated with endometriosis?
So it could be, because pain triggers a lot of receptors in your body. But when you're having a heavy menstrual bleeding, that can drop your blood level. And once it drops your blood level, you can get what we call anemia, meaning your blood level is low, there's not enough blood flowing in your body, so your system just shuts down. So that will mean that your blood levels are also critically low. But uncontrolled pain can do that as well, because it triggers some receptors in your body. Your blood pressures can drop, the low blood can cause that. So the fainting episode could be related to the pain, the stress level, can be related to a drop in your blood level as your period becomes heavy. So you have to exclude all other issues. Yes, endometriosis, the low blood level that can come with the heavy bleeding, can be associated with endometriosis, but it can be associated with other issues, some of which Bontle has mentioned, like fibroids as well.
Just a quick question. As activists, Bontle and Ole, this is from Nyakalo, what is the most common concern amongst women living with endometriosis? Bontle, let's start with you.
I think one of the most common concerns that I come across, just as I, was hearing everyone speaking, they've mentioned that when they were young or teenagers, myself included, they have been told, to try and fall pregnant, to try and, I don't know if it's to prevent it, or I'm not sure the reasoning behind it, but it's something so common. I thought I was alone, but I've come across so many people saying, why is this a priority to try and have a young girl or a woman fall pregnant to try to help this? And also just the normalization of pain and not really being listened to. I think it's important to really look at the multidisciplinary team, like Dr. Pule is saying, like it takes so many different aspects to address just, one thing, because it's affecting so many things, but just not being believed is such a big one as well. And not because I can sit like this and show up in the doctor's office and it's like, here's Panado. And this is genuinely what people say. I was told to take Panado. And when I say, no, here, this is what I've been recommended in the past, and they take it to their doctor and they're like, oh, my doctor was impressed with this. I'm like, what? So there's a real gap. Some of us are fortunate to have found really amazing doctors, but there is the other side of it where it's scary, so it's a lot of things.
Sure. Ole?
Yeah, I completely agree with what Bontle is saying. I mean, a person that lives with endometriosis, even at work or at school or in any environment where they have to actively participate, looks normal on the outside. They look normal. It's very difficult for somebody to believe that you are actually ill, whereas you are battling heavy bleeding, chronic pain, inflammation, and all the other things that it comes with. So the being seen or being heard or being believed is really true. Because it kind of, if you don't have those debilitating symptoms, your employer takes it for granted that, I mean, you're okay, you can do this. So I think it's really the lack of information as well. I think my biggest concern is that it's lack of information, and people don't have information. And when it comes to women's reproductive systems and organs and processes, there's a lot of shame around that. And so we tend to be embarrassed to speak about those things. Those are things that, I kept hush, that you can't speak about in public, or the perception is that, you can't bare yourself naked like that in the public or at work or in the presence of men or in the presence of your brothers, or in the presence of any male person. But that makes it difficult for them to be able to support us. So I think it's really important that we keep on talking about this. And a lot of us also don't have the courage to speak about that, because like Bontle says, sometimes you don't get believed. Sometimes there's so many languages and so many terms that people can attach and coin to a thing. You want to be relevant. You are suddenly an activist. And that it can discourage you. It can discourage one, but I think where we can, let us continue to spread the message. And not only to the people that already have the information, not only to the people that can get on Google and find out. There are so many people, you can imagine, in the communities that we work in South Africa, where they don't have internet, they don't have fully functioning medical facilities. You go to a clinic in the village and there's no medicine. The best thing that they can do for you is give you Panado, let alone understand how to explain to somebody that they have endometriosis in the language that they speak. So I think the challenges are really many, but I think let's keep the conversation going and hopefully make a difference, hopefully make an impact and help, other women, other young girls, mothers, grandmothers, employers in particular, to kind of know and be more aware and courteous on how to handle or live with people living with endometriosis.
Dr. Pule, Olebogeng at the beginning of the conversation spoke about the medication that she's on and how she does not get her menstrual cycle every month. Is that a problem?
No. So a menstrual cycle is regulated by a fluctuation of different hormones, and hormonal treatment mimic those fluctuations, or they prevent those fluctuations. So when a woman goes through her cycle, you have your normal, relatively, your hormones go through different phases. And one of those phases is a buildup of the lining of the hormone of the uterus that is driven by the hormonal changes. So when you take away those hormonal fluctuations by using a contraception or the medication that you use, there is no buildup of that lining. So there's no lining to shed. And contraception tend to do that. Some contraceptions, not all of them. And it always also depends on a woman's cycle. Is your flow regular? Is it heavy? Is it the clots? So depending on your hormonal level, your cycle length, or the volume of the blood that comes out, it will either reduce it, regulate your cycle, or stop it completely. So not everyone reacts the same to hormonal treatment or contraception. So there is no buildup of blood, because the buildup of blood is driven by the hormones. And if you're blocking that pathway, there is no blood that builds up and gets blocked.
You know, at the beginning of our conversation, ladies, I said endometriosis, the good, the bad, and the ugly. During this conversation, I'm not sure if there is a good to endometriosis. It just sounds like it's just bad and ugly throughout. Is there anything that you would say maybe there's a positive to endometriosis, Bontle?
Yeah, for me, I advocate because I believe not that there is good with endometriosis, but for the fact that there's no cure, I don't believe that you cannot be, how do I say, like healed. I think you can still be whole, you can still find purpose and be enough, and your identity isn't in you having children or you not being ill, you know. So for me, the biggest thing driving me and speaking to other people is that you are more than enough, and you can be used in that space and in where you're at, you know. So I've found purpose in it, but I believe it's also like a special calling, because for me, I've just I've shared, I've put my whole entire life on the internet, and I believe some of us are meant to, not everyone, but there's someone in the corner who's always listening or learning. And for me, I believe you can find purpose and in whether you're in finance, whether you're, you know, in catering or whatever space you're in and you have the illness, it's one step to educate someone. And so I think it can change the world in some way if we speak, if we talk to the family, if we speak to our partners, the schools, and then that changes, you know, the workplace, and then legislation, and then the world, hopefully, you know. So I guess that's a little bit of good with it.
Ole, a bit of good?
I couldn't agree more. There's nothing to celebrate about endometriosis, but I feel like if you have it and you have a voice and you have the opportunity and the resources, it ultimately becomes good in that you can share those experiences to help educate others, to help create more awareness, and also to just understand certain people. Sometimes you don't even have to do grand things like speak, educate, write, but you can be in a position of understanding, and therefore you become kinder, you become more gracious or generous to people, to women. You also are in a position to help other women feel less lonely, because it can be a very lonely journey. It's not a lot of people, as much as we come across a lot of women that have it, but it's not a lot of them that speak openly about it, or that are as empowered as some of us may be. So just to be able to say, I understand, let me maybe take off that load from your hands, because I get it. I get what you're going through. You can see a woman walking there, and in just how they walk, you can tell that she's struggling. And that puts us in a position of being able to extend a helping hand or a listening ear and just some form of support.
Dr. Pule, at which point do we come to you as women? At which point do parents send their young children to Dr. Pule, an obstetrician and gynecologist, to get themselves checked out? You know what Bontle said, actually, before you answer this, the issue of having terrible period pain, and then you get told, just have a child. I got told that by I don't know how many gynaes, just have a child. It will all go away. But it's not, that shouldn't be the way that we should be going, right? But also, when do I come to you? At which point do I say, this is now getting out of hand?
Okay. So the hero of having a child is because what we call nulliparity, not having children, is considered a risk for endometriosis. But like all the other factors I've mentioned, your weight, having a family history, there are other risk factors that one might not have control over, right? So having a child is not a solution for everyone or to everything. So treatment needs to be personalized, and encouraging people to have children when you're not actually addressing the problem is a problem in itself, because bearing children alone can predispose you to other things. So you have to personalize treatment, and advising people to have children to prevent endometriosis is not a solution, because there are other risk factors, there are other exacerbating factors. So you're not addressing the root problem.
And at which point yes.
Pardon?
At which point do we come to you? At which point do parents send their young ones to you?
Yes, so when I speak to parents and young girls and women, when a parent starts seeing their own doctor, regardless of which doctor it is, we need to sensitize our children to having access to healthcare professionals, speaking openly to healthcare professionals, affording them those personal spaces in their own right when they become of age and mature to say that, you should be seeing a healthcare professional if you are concerned about 1, 2, and 3. But the red flags for endometriosis, so if a child is starting their cycle, first and foremost, some parents are not comfortable with just having gynecological women's health talks with their daughters. If first that's a conversation you're not sure about or you're not comfortable to have with your daughter, come into the office. You can come and consult. But concerning symptoms would be the debilitating pain that I'm talking about, irregular cycles, when a child is not able to get out of bed, or you have a lot of school absenteeism that is related to their cycle, where there is heavy menstrual bleeding, when someone needs to change a tampon or pad every other hour, filling in a pad or a tampon every other hour, severe nausea, vomiting, and just all of those things. But I always encourage parents to sensitize their daughters or their children to get into contact with a healthcare professional before the problems arise. And if parents are having conversations that they deem difficult or they are less informed about, that's another reason to get in touch with a healthcare professional who is knowledgeable on the particular topic that you find difficult for you to speak about to your daughter. So I encourage parents to not just wait for problems, to have to function from a position of power. So be informed. As we are saying, society either has normalized pain for women, and it's unfortunate that the pain threshold for Black women everywhere in the world is supposedly much higher than our counterparts. So that's the other problem. But we do need to invest a lot of research and encourage our government policies and everything really to advocate for women's health care and take into consideration the pain and the cycles that we go through in our everyday life. But I always say, do not wait for the problem to escalate, and do not normalize pain or period pains. If someone is crying out for help, at least afford them that platform to say, you know what, let's get it checked out. Regardless of what kind of pain you are going through, if someone is concerned about their body, rather afford them the opportunity to see a knowledgeable healthcare professional. And pain thresholds are different for everyone. And the stage of endometriosis does not determine the amount of pain that you will feel. So pain will differ from woman to woman, regardless of whether you are at stage 4 or whether you are stage 2. That does not determine the amount of pain that you will feel. So I encourage parents to see healthcare professionals before problems arise, just to educate themselves, to be aware, either you see a gynae or a women's healthcare professional prior to your daughter going into their cycle or period, or for parents who are not comfortable with having those kind of conversation, healthcare professionals are there, and all the other symptoms that I've mentioned that they are not normal, then that's when you should also see a healthcare professional.
Perhaps just share your details with us, Dr. Pule. How can we get in touch with you?
So I am in Johannesburg. I'm based at Arvate Medical Center in Kempton Park, and we have sessional rooms at Raslo Hospital in Centurion. But I'm also on social media at Dr. Gynae Mom, that's a personal page, and Dr. Koketso Pule, and also on my LinkedIn. And I welcome any questions in the DMs. I will not do personal consultations, but I can give advice and offer referrals and advice if needs be.
Olebogeng, how do we get in touch with you, ma'am?
On TikTok, it's Endo Warrior 1, as in the yoga pose Warrior 1.
Okay.
Endo Warrior 1. And then LinkedIn, that's the only other social media platform that I have. It's Olebogeng Kgosilentswe, but my WhatsApp number is 083 4477 861 in case anybody would want to have a conversation.
Thank you for that. Bontle, how do we get in touch with you and get your book?
Okay, so I am at endometriosis.za, but you can find my little baby at Heal Endo Movement, but that's spelled HealEndoMVMNT. And my book is on Amazon, currently out of stock, so I'll have to figure it out. So for now, people can get the ebook titled Church and Memories of His Bathroom Floor.
All right. Thank you so much, ladies, for your time. Thank you for this wholesome conversation. As long as we didn't find the good, but we're able to unpack, what endometriosis really is all about. Thank you so much. Truly appreciate it.
Thank you for having us.
Thank you, Tshegohaco. Thank you for having us. And thanks to Dr. Pule and Bontle as well.
Thank you
Thanks
so
so much,
much.
ladies.
Dr. Koketso Pule, she is a gynecologist speaking to us about endometriosis, helping us understand it in a wholesome way. Olebogeng Kgosilentswe, she of course is an activist together with Bontle Moka. They have been speaking to us about their journeys and also just, how we should be a bit more kinder to one another as well as women. And the big thing about this conversation that I've taken away, do not normalize pain. If it's painful, get it checked out, especially if you're going through a menstrual cycle. That's how we end off this conversation with Eminent Women. I hope you've enjoyed it as much